I would like to take a moment to introduce our team. I'm going to ask everybody when I announce them to wave and say something so their box lights up and you can see their smiling faces. My name is Karen Henshaw. I am the Associate Program Director for the Connections in Health team. We are housed at the IU School of Medicine at the IUPUI campus, and we are part of the Indiana Clinical and Translational Sciences Institute. And we're in the county engagement arm called Community Health Partnerships. So the first person I want to introduce that I didn't warn is Gina Claxton. She is our program manager for Community Health Partnerships. Hi, Gina.
Good morning.
Okay, thanks, Gina. Next, I would like to introduce Alia Amin. She is the Cardiovascular and Diabetes Coalition of Indiana Coalition Lead.
Hi, everyone. Happy Thursday.
All right. Next, we have Antonia Sawyer. She is the Hoosier Health and Wellness Alliance Coalition Lead.
Good morning, everyone. Great to see you.
Courtney Stewart is our Indiana Joint Asthma Coalition Lead.
Good morning. Happy Thursday.
Aaron Zich is our Project Management Coordinator.
Good morning, all.
Lily Derbyshire is a PhD candidate at Purdue University.
Good morning, everyone. Happy to be here.
And Donna Vandergraaf is our Purdue Extension Liaison with the Connections in Health team.
Good morning, everyone. Welcome to a beautiful Thursday morning.
And finally, I want to introduce Dr. Dennis Savaiano. He is the faculty director for the Connections in Health project. He's a professor at Purdue and was instrumental in getting this project off the ground. And I am going to turn it over to Dennis for the welcome.
Let me add my welcome. I'm delighted you're with us. Thank you. Thank you for your involvement and your interest and your commitment to this effort, which we believe is a really critical effort for the state of Indiana. We're looking forward to a great day. I will tell you that this staff has been absolutely amazing to work with. They have prospered through the pandemic in terms of their relationships and their building partnerships. Karen has led them masterfully, and I couldn't be more pleased with the staff that we have. Connections in Health is an amazingly unique opportunity. The hundreds of individuals and organizations that are partnered with the 3 health coalitions that we oversee are an amazing group of people that I really believe together we can collectively improve the health of a state that clearly needs our help. The Indiana State Department of Health has been a wonderful partner, a funder who has moved money from CDC through their block grant program to this activity to fund the salaries of the staff. The Indiana CTSI has been a great home for us for the last 3 years, giving us access to resources, people, expertise that we couldn't otherwise have. They've been a great partner along with Notre Dame and Purdue and IU. I'm a Purdue professor and we have tremendous athletic rivalries, but in Indiana, these universities are amazingly collaborative and working together. And we have great faculty and partners at all of these campuses. And we have a new partner. We have recently entered into a subcontract with the Purdue Healthcare Advisors, who are managing a good chunk of the new health equity grant funds that are coming from CDC through to the state of Indiana. And so we're going to be involved in their work in helping them and assisting them in evaluation and in assessment of current counties and their efforts toward health equity. And we can perhaps talk a bit more about that. But Indiana continues to be challenged, as I think you all know. The culture of health in Indiana is not what we would like it to be. Clearly, health has to be elevated. The pandemic is actually an opportunity to do that. So we have a lot of work ahead of us. But let's celebrate a little bit. The last 3 years have been an amazing evolution for Connections in Health and the coalitions we manage. The Hoosier Healthy Weight Alliance or Healthy Wellness Alliance. I keep saying weight. Sorry, Antonio. The Asthma Coalition, the Cardiovascular and Diabetes Coalition have all seen incredible growth. You'll hear more about that in some of the breakout sessions today. And that progress is phenomenal. We are so proud of what we've done, but I would argue with you that our greatest challenge lies ahead of us. Translating what is statewide effort into local community action is a tremendous opportunity and a tremendous challenge, and doing that effectively, I think, is what we're going to focus on in the years ahead. It's extremely difficult. It's extremely difficult in the nature and the culture of Indiana, but we really owe it to the state to move the needle. We're all in this together. We need you. We hope you need us. We're here for you. We see this as a sustained, an ongoing effort, not something that's a pop in, pop out. And I think that's a key. We see it as building trust and building partners. And so with that, I look forward to the rest of the day and to the breakout sessions. And again, thank you for joining us and thank you for this opportunity. We are truly fortunate to be able to do this work and move the needle in health in Indiana. Karen?
Thank you, Dennis, for your words of wisdom and encouragement and sharing about the Connections in Health project and what we are hoping to do moving forward. Moving on, we are going to move on to our first set of breakout sessions here briefly. And what will happen is that we will post links in the box. You should go into a waiting room until the time comes. So go ahead when you're ready and click on the link that for the breakout session that you would like to attend. There is Crushing It During Challenging Times. During that one, you will hear from Purdue Extension staff, some Connections in Health team members, share about how forced opportunities led to stronger community relationships despite physical distance. The other opportunity for a breakout session this morning is Let's Go on a Coalition Trip. That will be some of our Connections in Health team members sharing about how to navigate through Coalition Trip to access resources, improve communication, effectively assess your community's needs. So at this time, I'm going to ask that you go ahead and select whichever breakout session you would like to participate in. And then hopefully you will hang out in the waiting room until it's ready to start. So we will see you there.
It's now my pleasure to introduce Dr. Lindsay Weaver. Dr. Weaver joined the Indiana Department of Health as Chief Medical Officer on February 3, 2020. She brings to the role a passion for both emergency medicine and end-of-life care. Dr. Weaver is an assistant professor of clinical emergency medicine at the Indiana University School of Medicine and practices emergency medicine at Methodist Hospital in Indianapolis. She is board certified in both emergency medicine and hospice and palliative care medicine. She earned her undergraduate degree in biology at the University of Kentucky and graduated from the University of Louisville School of Medicine. She received residency training in emergency medicine and fellowship training in hospice and palliative medicine at Indiana University School of Medicine. And she completed a fellowship in ethics at the Charles Warren Fairbanks Center for Medical Ethics at Indiana University Health. She has served as quality director for the Department of Emergency Medicine and physician lead for the System Sepsis Steering Committee at IU Health. She also served as executive director for the Indiana Patient Preference Coalition and as president of the Indiana chapter of the American College of Emergency Medicine Physicians. Dr. Weaver and her husband have 5 daughters. Thanks for being here, Dr. Weaver.
Thank you so much. Thank you for having me. I will confess at this time that I am recovering from a non-COVID little upper respiratory infection. So I apologize if I have to unmute to cough. I am doing much better, but still recovering. Just going to share my screen here quickly. Start at the beginning. All right. Good morning, everybody. Thank you so much for giving me the opportunity to talk to you all about how we have used data during the pandemic. I don't know how many of you were able to tune in to any of the governor's briefings since the beginning, way back in March, but he, and as well as Dr. Box and I, would frequently say that we were making data-driven decisions, and we absolutely were. Every single day, weekends included, late nights, we were reviewing any and all data that we could possibly get our hands on in order to inform the governor and the public on what steps we needed to take with mitigation, where we were with hospitalizations, where we were with cases. As you all know, it has been a very fluid situation as we learn more, as more studies and information come out from across the world, as the CDC updates their guidance. And just honestly, the patterns of human behavior and how they have changed throughout the pandemic has significantly changed how we have approached things. So I have very few slides with words on them. And in fact, I'm going to stick mostly to the data and to the information that we have tried to share with everyone. From the beginning, it would be very important to be profoundly transparent. We have a large team that works very hard on our coronavirus .in.gov dashboard that tries to get information out there in as much as real time as possible. We understood from the beginning that if we were transparent, that would help us to gain the trust of Hoosiers, that we were trying to do the best we can with the information that we received. Now, there was absolutely times where we kind of found out after the fact that we, for example, hadn't received, a couple thousand tests from a lab who was testing and did not make us aware they were testing and were not reporting as mandated. And so then we would have to, for example, dump in a bunch of labs. But we immediately came to the public and informed, hey, this is a situation. We found out we're going to have all these extra tests and positive cases that we're going to have to add to our dashboard. But we believe and we hope that by being transparent, even though it's sometimes, hey, FYI, something went wrong, that we therefore were able to gain people's trust. So this is not directly from our dashboard, but is a slide. These are our cases from yesterday. I was hoping to get you the updated ones from today, but there is a delay in getting the data. We have lots of data points that are coming in and it's scrubbed for information. So some of the decision points where we had to make decisions, even just simply about cases, is at first it wasn't being recommended that we count antigen testing. So the antigen testing are those rapid tests that now you can buy off the shelves. And so at some point those were not being counted. And then we made the decision that we would include those in cases, that we got enough information, enough data that those were good tests that we could therefore use. And so those were added into the dashboard. At-home tests are not added into the dashboard. We have no way of collecting that information. I know that some of them have connected to an app, but that app does not connect to the states in order for us to get those tests. So we know when we're looking, for example, at this screen, and we look at the total number of cases, that we are missing a lot of cases. I mentioned earlier about the change in behavior as well. People are getting tested at less high frequency than they were back in this spike that you can see from September into March. People are very interested in getting tested during that time. That was before vaccines. I feel like after that spike, after vaccines came out, people are either like, I'm vaccinated, I have a cold, I don't need to get tested, or they're just frankly over it, and therefore not getting tested. So when we look at these numbers and these cases, we know that we could be missing as high as 3 to 1. So 3 more cases for every 1 that we have accounted here. And that information is based on data from studies where they do antibody testing, of course, before the vaccines. So deaths is something else that we, of course, have been very transparent and reporting to people. So for deaths, we do have to have a positive COVID test documented, and then of course, reported as a COVID death, like from a provider or from our long-term care facilities report them as a COVID death, or I guess they have COVID listed on their death certificate. Before we had adequate testing, there was absolutely COVID deaths that we did not have a COVID positive for, and so those cases are listed as probable. You can see that down there in that left corner. So those are cases that there was not the opportunity to test or adequate testing at the time, but the physician who was caring for that patient felt the patient had all the clinical criteria for it and therefore listed COVID on their death certificate. We also talked about a lot back at the beginning of the pandemic and through last summer about guiding principles. So how are you making decisions about mask mandates, about limited capacity in facilities, et cetera? And so one of those guiding principles, or principle number 1, was hospitalizations. So, the big reason back in March of last year to, really limit people's limit capacity at facilities, and the restaurants were closed down, and everything was pretty much stay at home, was in order to protect the hospitals and give them the opportunity to prepare. So the opportunity to get the personal protective equipment that they needed, like the face masks and the gowns, which they were very short of for quite some time, the ability to get more ventilators, the ability to set up more rooms that were able to take COVID positive patients. And we were successful. The hospitals were not, for the most part, there definitely were some, but were for the most part not overwhelmed in Indiana in the beginning. So paid very close attention to COVID-19, hospital census, and inpatient admission. So this is just recently, since the beginning of August through September. And it is definitely a different situation. So as you know, there are no capacity limits anywhere. There's not a mask mandate. People are freely moving about and around. We do have vaccines that people are able to take to protect themselves. And we are seeing high cases of hospitalizations. I have a slide later where I will show you that they are by far in majority unvaccinated people. The other problem here is that back, in March, is people just weren't seeking healthcare. They weren't going to the hospital for things. Now they are, and we are seeing a lot of sick people, not just COVID people, in our hospitals. And so our hospital beds are full across the state. In addition to that, we have seen a lot of our healthcare workers leave the healthcare workforce in the last 6 months. And that has also led to our difficulty in being able to really take on this influx of patients. So the hospital beds are full. I've heard people say, well, they say they're full, and it's not just because they don't have enough staffing. That's not true. They are actually full. Like, all the beds are full. They're moving into spaces where they typically don't put patients. But on top of that, they're also taking care of all those patients with less staff. So here you can see our ICU bed across the state has gotten smaller and smaller with each passing day, still showing capacity with our ventilators, and then also hospital beds. We implemented last year, speaking of data, these advisory level county metric maps, which were meant to be used by counties to help direct, communication in their community about the level of spread, and also, when they were doing any types of restrictions. So a lot of work went into making this map what made the most sense to signify significant spread. I will tell you then the positivity rate made a lot of sense. There was a lot of focus on that. Now I tell people to focus more on the cases per 100,000 residents. That positivity rate is so much affected by people's willingness to get tested. It's affected by the amount of screening testing that's occurring. So for example, in college towns, when they were doing a lot of screening testing last year, may have had a falsely low positivity rate just because the just significant numbers of screening testing that they were doing. We still provide this information. It is still used as a reference point for people locally and also for us as a state. Our goal is to get back to having all of those counties blue, which we were pretty close to in June. The other thing we used data for was to address disparities. And I will tell you from the beginning, it has been very difficult to collect the level of race and ethnicity information that we need, despite it being mandated to be reported to us for tests. A lot of EMRs, so hospitals' record systems, as well as labs and the pharmacies, were not set up to collect that information and then send it to us. So connect that information they have in their EMR to a test that had been done that then needed to be sent to the Department of Health. So we made sure that our systems were collected up in that way to do. So we, all of our testing and vaccine sites use, we work with Zotec and to provide a Zotec application. So we do collect that information there. Anybody that we partner with to work on behalf of the state, this is all an expectation. And honestly, it is mandated for everyone to report it, but it is shoddy at best, unfortunately. But this is the best information that we have, and we do know that some disparities exist. So you can see here that the percent of cases for Black and African American is 7.4, which is less than what the Indiana population is. But we recognize this early, that also lower rate of actually getting tested. So we've made progress here, making sure that testing was available in areas so that all, despite your race, ethnicity, where you live, that you had access to testing. That number used to be, that difference used to be much wider. But again, it's difficult to say. You can't say that our Black and African American population has actually had less cases, because we know that they have been had the opportunity to get tested less. So those are the types of things that we pay a lot of attention to. We also map this across the state. Where are testing locations? Where are our populations that have a high social vulnerability index? Where are minority populations? What can we do to make sure that the testing sites that we have in those communities are ready to receive and make available, whatever is needed at the testing, but later on, it became about vaccines. Also, in discussing disparities, you can see that this other race, which when we break down this other race, it really does seem to be people who identify as multiracial are in here, is a big population of our deaths. So it's unfortunate that we do not have kind of more of a breakdown there. These are multi-system inflammatory syndrome in children, and we do see here a disparity in the number of cases in Black and African American children. This is actually worldwide, where they see a higher rate of the multi-system inflammatory syndrome in children in Black and African American races. So I mentioned before addressing disparities in vaccines as well. So we look very carefully at race, ethnicity, also age and location for vaccine disparities. This is by population, so you can see that our older generation who were more motivated to get vaccinated, of course, at higher risk for serious outcomes from COVID-19, and that the numbers go down pretty significantly all the way down to our 12 and 15-year-olds at our lowest rate of only 30.5% fully vaccinated in that age range. We did hear over the last couple of days that Pfizer does plan to submit their 5 to 11-year-old EUA in October, and will follow 4 to 6 weeks later with an application for EUA for 6 months to 5. We pay very close attention also, as I mentioned, to locations and recognize the disparities based on where you live. So this map shows by zip code the percent of the population that is vaccinated, and you can overlay a social vulnerability index map right over this, and it is pretty much, it's right on. I will say I am incredibly proud of the work done in the Marion County area. There's been a lot of directed work to improve vaccines in Marion County, and we work with these local counties that cover these zip codes to help improve vaccine rates there. This is also, we use maps such as this to direct where our clinics go. So every week we go to upwards of 50 different locations to do pop-up clinics for 3 to 2 days, where we offer PCR tests, we offer the Bionex rapid antigen test, we offer the Pfizer vaccine and the Johnson & Johnson vaccine at all these sites. And we use maps like this about that, whether or not they have low vaccine rates. We look to see if they have any vaccine sites. We look at their rate of testing, where testing locations that they have. We look at school-age children cases. So if an area pops up as having a high number of school-age children cases, but limited access to testing, that would be a reason why we would choose that location to go provide a pop-up site. So these are the types of maps that my team looks at several times a week to help direct where we need to go. So we also use data to predict and plan. It's hard to be prepared if you don't know where you're going. That was profoundly hard in the beginning of the pandemic, when really just none of us had any information. And every wave seems to be a little bit different and have its different nuances. So we just always have to be ready to pivot. And, I talk to my team about that a lot, that, sometimes we just have to try and do something, and maybe it's not going to work, but at least we try. We just have to be prepared to pivot. Same thing with the boosters that are coming out. We believe here in the next week or so, we don't know if they're going to come out and say that the boosters are available at 6 months, 8 months, or 10 months. We don't know if they're going to say it's only eligible for 50 plus or only eligible for long-term care facilities. So our team has been planning for every single scenario. We looked back at that. I don't think I actually have that map, but we have a map of vaccines over time and have plotted out 6 months, 8 months, and 10 months later when all those people would be due for their booster. So we know exactly how many vaccines we need to plan for giving at those times. We also use maps like this. So this is a trend of cases since the end of August. And we actually saw last week a decrease in cases for the first time in 9 weeks. I will also say in the week prior, you can see that that sharp line up starts to make a bend when it goes from 3,800 to 4,200. So it was a slower rate and increase in cases that week. I know that we're going to have an increase here at the end, but I don't think, or we don't think we're actually going to go higher than where we were at that 4,200, but we will see. This is a 7-day average, of course. We will see where we land there, but we were predicting that we'd be reaching our plateau here this week or next week. But the holiday weekends, I will say, do always throw a curveball on that because people don't get tested at that time. The issue is even when you plateau with your cases, it's good, you're headed the other direction, but we know our hospitals still have several weeks of climb before they reach their peak. So hospitalizations tend to peak 2 weeks after the peak in cases, and deaths peak 2 weeks after the peak in hospitalizations. That's just kind of the nature of how the disease plays out. We did have a slight dip in cases last week, hospitalizations last week. Again, we feel that was contributed to the holiday weekend, but we'll see at the end of this week where we actually end up landing. Oops, sorry. So speaking of predicting, we're also always paying attention to the states around us and to what's going on across the US. So this is from the New York Times. This is their COVID tracker. I do like it. It gives me a good snapshot of information and easy to compare between the different places. And you do see a decrease in cases and hospitalizations across the US, which is a really good sign. You can see here that the Midwest in the green has shown a little bit of a flatter curve compared to that huge spike in cases that we saw in the South, and a lot of the states coming forward and saying that they were completely full and out of ICU beds. You can also see how Tennessee is a big outlier compared to the Midwest, West, and Northeast. This is Louisiana. Only reason I bring up Louisiana is that they were one of the states to peak first. So you can see they start to peak early July, and now have been going down in cases for the last month, just about. So we look at things like this to kind of plan, okay, how many weeks do we need to be in full surge mode? Will our hospitals have enough PPE? Do they have ventilators? Where do we need to move ventilators to? But just timing really helps with planning. So this is Indiana. You can see that last week we did see a slight drop in cases, 1%, and our hospitalizations are still rising, but not quite as fast as they had been the week prior. In comparison, looking at the states around us, Kentucky has seen a huge surge, their biggest surge throughout the pandemic. Their hospitalizations are pretty at their limit as well. Also saw a small decrease in cases and a lower rise, 14-day change in their hospitalizations. Illinois rising pretty fast, positive 47% in cases and hospitalization. So something for us to pay attention to. A lot of our Northwest hospitals do depend on Chicago hospitals to assist with transfers of patients. Ohio doesn't seem to be following the same high rise in cases as Illinois looks to be. So a much smaller increase in cases and hospitalizations. Same here, small or definitely increases, but doesn't seem to be peaking. Something else important to point out is the United Kingdom. Oh, I'm sorry, there shouldn't be an E on that. We also look to other countries when they, like when India had the Delta surge and the UK had the Delta surge. So they had this strange phenomenon where they actually peaked with Delta cases. They had a super sharp drop, but then increased again. So something I want to point out, and they're back going down again, but something I wanted to point out is that where that blue arrow is pointing is actually when they described it as their freedom days, when they stopped all lockdowns and stopped the mask mandate that they had there. So they had lockdown as part of the Delta surge. And then even though cases were still rising, went ahead and opened things up. So I think the guess is that, this peak was because of, all the things that were put into place, the mitigation measures that were put in place before the arrow. And then the rest, when this starts to kind of peak up again, was just, because people were out and about and moving once again. So kind of a delayed effect of that, which we would expect and we would see because everything's about 2 weeks with the COVID virus. So we also used our data to communicate. This is on our rshot.in.gov website. People always wonder, do the vaccines work? Absolutely, they work. So this is a breakdown of breakthrough cases, hospitalizations, and deaths, just to show that if you're vaccinated, your likelihood of being a breakthrough case, breakthrough hospitalization, and death is very, very, very small. And these are my favorite graphs because I think that they are just so profound in the message that they share. The top lines are the number on the left is the number of breakthrough cases per 100,000 vaccinated individuals. And on the right, the top line is the number, the 7-day average of breakthrough deaths in unvaccinated individuals. So the top lines are unvaccinated individuals, and then the bottom lines, that light blue and the light purple, are the vaccinated. So you can see on the left that the number of unvaccinated cases is much higher than the number of vaccinated cases. And then on the right, you can see the number of unvaccinated deaths is much higher than the number of vaccinated deaths. So I think it's just using data to display, you know, what we know and what we see with how well the vaccines work. We also use data to help develop policy or constantly reviewing information from other places. This is our schools. We are seeing a decrease in positive cases in schools, which is really good. We've had a lot of schools change their mitigation efforts since they started school. A lot of schools opened up, like, you know, kind of just like way back to normal before COVID, and then had a lot of cases, maybe had to quarantine a full class or even the school, and then came back with, you know, mask mandates or more spacing or, you know, just different mitigation measures. And because of that effort, we have seen a decrease in cases, which is really exciting. We looked when we have just recently updated that if a school is fully masked, so mandated masking, and that it's monitored so that they're actually masking, that they don't have to actually send home quarantine close contacts. The reason we did that is we reviewed this study, and I think that they actually just officially published this information, where they show that when everyone is masked, less than 1% secondary attack rate. So even if you have positive cases, they only spread less than 1% of the time when everybody was masked. And when they looked at it, it didn't matter the distance between students. So that is why we updated it to encourage schools to mask and really to keep kids in school, because that is really what our primary goal is. And and this study, as well as a case study here in Indiana, did show that that masking really does decrease the spread between these students. So I don't have the case study in here, but they showed very similar secondary attack rates when everyone was masked, and they saw 142% increase in the number of secondary attack in schools that were mask optional. So, all right, that concludes my presentation, but I am happy to answer questions.
Thank you so much, Dr. Weaver. We did have 2 questions that were entered into the chat, and I will invite the group if you have other questions. So please go ahead and enter them in the chat, and we will take the next 10 minutes to answer as many of them as we are able to ask Dr. Weaver. So the first question was, how do you calculate the social vulnerability index?
So we actually get that information from the CDC, and there is all different kind of levels that you can pull into your social vulnerability index. So that, of course, would be like socioeconomic information, access to has some urban rural information in there. So there's all different kind of levels, and you can kind of pick and choose how much you're using to inform you based on, you know, whatever it is that you're doing. But that is available through the CDC.
Thank you. Another question asks if there are maps that overlay vaccine rates with case rates.
You know, I don't know if there is one publicly. I can't say that I have looked at it. We have, you know, just kind of looked at it. It's really difficult to do that because it's just, as things change, they change so quickly. So one week it'll look like, you know, in a particular county, oh wow, they're doing really well with cases, they have a high vaccine rate. Within the next week, you'll see, well, that they'll have a higher rate of cases, maybe compared to the other counties around them. But again, most of the time in unvaccinated individuals, not that vaccinated people can't get cases, they absolutely do. But again, it goes back to those hospitalizations and deaths. I think it'll be very interesting to kind of go back and look at it after this surge. Some of our hospitalization data is delayed by several days because, you know, we have to get the information out of, hold on just a second, sorry. We have to get information from II CareWeb is where we're getting that hospitalization information. So, but I think that would be interesting to go back and look at hospitalizations and deaths compared to vaccines for different counties or zip codes.
Great, thank you. Another question, what are the characteristics of vaccinated persons who become seriously ill or die? Are they similar to those who are otherwise compromised?
Yes, so they are older, typically. They are, hold on, I actually have that. Let me get that for you really quick. So our solid organ transplant patients have been really affected by breakthrough hospitalizations and deaths. Unfortunately, they're just not mounting a good immune response to the vaccines. They don't to other vaccines. This is not special to this vaccine. Honestly, they're always more vulnerable, but we have definitely seen hospitalizations in them. Excuse me. So 92% of our deaths occurred in people 65 and older, and the average age of breakthrough deaths are 79. So people who are older and people who are immunocompromised.
Okay, thank you. I have one more question here that was in the chat. A school system just adopted mask mandates for when the county is in red or orange advisory levels. And the question is, do you recommend masking at all advisory levels, not just red and orange?
No, again, I'm very data driven. I think you look at the situation and you make decisions there. I don't want my children to be masked for all the ends of time. And so I do fully suspect that we'll have these waves, times where it is important in order to protect our children and other people in the community, and then times when the cases are low where it doesn't need to be needed. So I support counties and looking at what the current situation is. Right now, the entire state is on fire. So I would definitely support schools in implementing mask mandates during this time. But yes, here in the next 6 weeks, when cases are back down again, then it should be reevaluated.
Okay, thank you. Just one more question just popped into the chat. Any comparison between vaccinated versus unvaccinated and number of cases in each population?
Vaccinated each population. So is that or race, ethnicity?
Vaccine and unvaccinated cases. Kanza, can you define what you're talking about when you say each population? I think maybe the population is the vaccinated population and the unvaccinated population. Any comparison between those? Yes, she says.
For cases?
Yes.
Yes. So like who makes up those people? Is that what the question is? Sorry, we do compare vaccinated versus unvaccinated for the number of cases, and that's what that breakthrough case information is. So vaccinated people make up a very small number of breakthrough cases. Actually looking more into that population, to my knowledge, nothing, we haven't seen anything stand out where there's something that makes you more likely to be a breakthrough case other than if you're older or immunocompromised in some way.
Okay. Thank you so much. That was a lot of really interesting data and information. We really appreciate you taking time to put that together. And especially knowing that you're battling your own illness right now. So thank you for taking time to do that and to share with us today. I also want to take a minute to just express our appreciation to everybody at the Department of Health. We know that you are working around the clock and, juggling all kinds of things that are just coming at you all the time. So thank you for all that you're doing to protect us and to help educate us. And we hope that you can extend our appreciation to your colleagues also at the State Department of Health. So thank you, Dr. Weaver, very much.
Absolutely. Thank you. Appreciate you all.
Okay, we are now going to have an opportunity for movement. We are going to say, feel free to turn off your camera and join us for a few minutes of office yoga, but don't go away. Even if you don't want to do the office yoga, we're going to have a fun activity following that. So please feel free to turn off your camera and let's have a movement break.
Hi, it's Anjana from beautifulliving.com. This is your 5-minute break for office yoga. So go ahead and sit in your chair, come to the edge, and bring your knees right over your ankles, hands on top of your legs. Take a deep breath in, lengthen your spine, and exhale, relax your shoulders down. Inhale, you're gonna lift the chest up a lot, maybe take your gaze up, and then exhale, round your spine. So inhale, lift up. Puff up the chest, exhale, round. Inhale, and exhale. Inhale, and exhale. Inhale, come back up to a neutral spine. Interlace your hands behind your back. If you can't do this, then grab your arms somewhere, and then reach down. So again, puff up the chest, maybe look up to the ceiling. Deep breath into the chest. And I like to exhale through the mouth. Inhale. Exhale. Again, inhale. And exhale. Now take your hands over to your left side and drop your left ear over to left shoulder. So relax your shoulders down. You should feel a stretch along the right side of your neck. And just close your eyes, take a couple deep breaths. And lift your head back up to center. Take your hands over to your right side. And let your right ear fall to right shoulder. Again, relax your shoulders away from your ears. Close your eyes and breathe. Good, come back to center, release your hands, and then we'll take a twist from here. So take your left hand to your right knee and your right hand reaches behind at the back of the chair. Inhale, lengthen your spine. Exhale, gently draw your navel in as you twist to the right. Inhale, lengthen, and exhale, twist. Good, unwind back to center, other side. Grab back of the chair, inhale. Nice, come back to center. Cross your right ankle just above the left knee for a seated pigeon pose. So keep your right foot flexed. This might be already a lot for you right here. You can stay there, or you can start to fold forward, either keeping your hands on the chair. Maybe you can take your arms down, relaxing your head down. Breathing into intense sensations in the hip. And coming back up and switching side, take your left ankle above the knee, keep your foot flexed. Again, either staying here or folding forward. Good, and lift back up to center. And then come up to standing. We're going to come to ragdoll. So you can keep your knees bent, fold forward, grab a hold of your elbows or your biceps, and let your head be really heavy. So you can stay still, you can sway side to side gently. I like to think about kind of emptying out here and creating a lot of space, decompressing the spine. Good. Slowly roll up with your knees bent. And then come behind your chair. So hands to the top of the chair and walk as far back as you can, and then fold forward. So let your head rest down. You should feel a nice stretch in your shoulders and your upper back, maybe lower back, hamstrings, calves. Deep breath in through the nose, out through the mouth. Start to walk your feet back in. Inhale, sweep the arms up. And exhale, hands to heart center. Thank you so much for joining me today. Have a great day. I'll see you next time. Namaste.
Welcome back. Thank you for doing a short movement break with us. I hope that helps you feel a little bit more refreshed and ready to go. I see it's ready to go, and she's going to take it away with an activity.
Hello, everyone. Thank you for spending time with the Connections in Health team today and all our wonderful experts and presenters. You know me as Antonia Sawyer regularly, but this is Look What Happens Live with the Connections in Health conference today. And I have a very fun scavenger hunt for you. So if you're familiar with Andy Cohen, he is a celebrity interviewer, and he has a fun little game where he interviews celebrities, but he gives some key words. And these words are for the audience to see if these presenters say them. So I'm going to switch it up a little bit, and I have some key items that I think you might select that really are the epitome of what the pandemic represents in your house. So I am going to give you about 2 minutes to go on a scavenger hunt in your house, find one item that represents the pandemic and quarantine for you. You see this item and you think, that's COVID-19. It's written all over it. So I'm going to have Lily cue the chicken dance song. You have exactly one chicken dance song worth of time to shut off your camera, go find one item that represents the quarantine or COVID-19 to you, and then come back. Do not turn your camera on until I cue, and then we will see what everyone selected. If you selected one of the key items that I believe represents COVID-19, you get bragging rights for the next year. All right, here we go. Well, I should count down. 3, 2, 1, go find your item. Lily, cue me the chicken dance. Thank you, Lily. Okay, now everybody flip your cameras on and put your item that you've selected up to the camera. I've got to see this. Let's see what hand sanitizer. Abby in with the hand sanitizer. A mask, Karen, that's good. Oh my gosh, toilet paper, Molly Hogue in with the toilet paper. Masks, hand sanitizer. What do you have, Jamie? What is that?
Oven mitts. We did a lot of baking.
You did a lot of baking. Oh my, oh, Ben and Jerry's tonight dough. Okay. Is that the potato chip, chocolate covered potato chips one?
No, I didn't even know that that was a thing. No, this is my favorite ice cream flavor ever. And I consumed an embarrassing amount. It's like cookie dough, and it's peanut butter cookie dough and chocolate and caramel ice cream and a bunch of other good, but really bad for you stuff.
That is awesome. Danielle, is that your phone? Why does it represent COVID for you?
Because lots of FaceTime, had doctor's appointments on my phone, work meetings. It was the one stop right here.
Oh my gosh. Okay. You guys are really doing well. I think everyone's going to have bragging rights when I read you my list. Okay. What do we have some animals. Who's holding a pet? Oh, Aaron said he had to leave, but I think Lily had a doggo.
Okay.
Aaron, there you are with your kitty.
Sure do. This is Wiehe, and she has a sister, and we call them the COVID twins.
The COVID.
You're COVID, aren't you?
Seth, what did you have holding up? I saw an orange book.
I was the first Harry Potter. I read a lot.
Okay, you read a lot. And Seth sells books too. So it's pretty cool that he loves to read, you can tell. I see some crayons, some erasable markers. Angie, did you spend a lot of time coloring adult words? Like the F word and the S word, because we were just all feeling it. Oh, you're muted. Now you're not, I don't think. Oh, you're still muted. We were going to play it's the blank for me, and I think it's the we can't figure out Zoom for me. That has really just grayed my hair through COVID. Okay, so I'm going to read you my list. And Alia, what did you pick? Now that you're on my screen really quick. Lysol, hand sanitizer, same diff.
Yep, Lysol spray.
Lysol spray. Okay, so sorry, I'm like, hi guys. I was trying to read your screens are about like this big. Okay, so if you had a phone in your hand, I picked phone because of TikTok, FaceTime, TikTok. Did I say TikTok? Okay, TikTok, right. I think someone had toilet paper. Who had toilet paper? That's definitely a bragging right. That I ordered Charmin. I did not get Charmin. Okay, I think I got some of those plants that you get when you go camping. That's what came from Amazon. Okay, so toilet paper definitely. And all of you that had food or oven mitts or a scale, maybe the extra 10 COVID pounds that I'm carrying around, we all felt that. And lastly, did anyone have a remote control? Did anybody Netflix and chill or binge watch TV? Our son's wife ordered toilet paper and got industrial.
I had a remote.
You had a remote, Courtney. It's written on there somewhere. It says remote.
Do I win something?
Bragging rights for the next year until next year when I do another scavenger hunt. You gotta, you know what? I'll spray paint an old remote control that I have gold and get my husband's like note thing that takes a like label printer, and I'll put winner. How's that? Sound good?
I would like it in a shadow box, please.
In a shadow box. Okay. Sounds good. Well, thank you all for participating. I did not put hand sanitizer on there because I thought it was so obvious, but it looks like I should have gone with that. I think 80% of you had a hand sanitizer or a spray. So seems that should just go on the list as impromptu, but awesome. Donna, what did you say? Who's muted? Oh yeah, you're muted is the phrase of the pandemic. Yes, you can't get through a day without it. You just can't. Awesome. Well, thank you for participating and playing Watch What Happens Live with Antonia during our conference today.
Thank you, Antonia. Okay, we are going to move to our second set of breakout sessions. And I just put a link to the entire agenda in the chat box, and Erin just put links to the 2 breakout sessions specifically. So at 12:10, we will be offering these 2 breakout sessions. One is about joining Indiana Healthy Community, collaborating to improve the well-being of Kosciuszko County. You will hear from Kosciuszko County Coalition members on how they have persevered through a pandemic. Your other option is to join Integrating Mental Health into Chronic Disease Prevention Strategies, an opportunity for change to understand how health coalitions can play a vital role in connecting chronic disease prevention and mental health. So go ahead and click on the link of the breakout session that you would like to join. You can leave this meeting, and at the end of that breakout session, we will come back to this main Zoom. See you there.
I want to know your name, man. I want to know if you got a man. I want to know everything. I want to know your number.
Dr. Wiehe is the co-director for the Indiana Clinical and Translational Sciences Institute, where Connections in Health is housed. Please join me in welcoming Dr. Wiehe for closing remarks.
Thank you. Wow, what a terrific conference. Thanks to all of you for joining us today. First of all, can you hear me okay? Okay, great. I was jamming out to the music that was on there, so making sure I didn't mess something up. Okay, so as part of these closing remarks, I reflected on coalition resiliency in a pandemic world, and I thought of my own experience during this wild ride that we've been on. As many of you know, I assumed the co-director role of Indiana CTSI just as the pandemic was coming to light. And both the new role and of course the pandemic were not anticipated, and they have challenged every aspect of my life, personally and professionally, and certainly the intermixture of the two. So that is essentially what I wanted to reflect on briefly with you today, the intermixture of our personal and professional lives and the potential of resiliency, which spans these aspects with the connections that we make. So as we were shut into our homes, isolated from physical interactions with our colleagues and our friends and our family, and in my case, figuring out a new role as makeshift elementary school teacher, as I'm sure many of you were, our lives were turned upside down. There was no longer work from 8 to 5, not that it was always like that for me, but my work and my personal life became completely intertwined. And at first, this was extremely stressful for me, but there were aspects I enjoyed. I saw my son during the day, watching him work, seeing his frustrations and helping him through them, encouraging his increased independence and overall feeling like I was a more integral part of his life. But I also saw things that I hadn't before in my meetings with colleagues. I saw their kids, their pets, their partners, where they were working, the books and artwork in the background. And in many ways, some of the natural barriers imposed by physically being at work sort of melted away. And as people felt comfortable, they shared more about their lives. I heard stories about their kids and their families, the stressors ongoing, and this bubbled over to other interesting and sometimes non-work related topics. And I also witnessed the incredible outpouring of support. For me, for those who were going through trouble that was pandemic related or not, and a demonstration of tremendous empathy and compassion that I frankly had not seen before. So what is the silver lining here? I had relationships with my colleagues, many of whom I would call my friends, even prior to the pandemic. But as we traveled through the pandemic together, I felt a closeness I hadn't experienced previously. The support penetrated deeper into my life. We demonstrated our resilience, not only as individuals, but as a team. Likewise, I saw the pride and the strength of the coalitions during this time. The trusted relationships had been developed already, so the pivot to a virtual engagement and collaboration was not as impossible as it may have seemed before. And in some cases, it may have galvanized the trust and even deepened our partnerships. So I want to pause here because I think this is really, really noteworthy. We, of course, can't sit on our laurels here, as there's always so much more to do, more communities to engage, more inequities to tackle. But our network in some ways proved their worth, and it grew. In some ways, it was easier to meet with folks, and meetings happened with folks separated by 2 to 3 hours driving distance, as it was as simple as a Zoom connection. Not that that's always easy. And often this was expanded to more people who cumulatively were separated by dozens of hours in driving distance. We have had success using coalition approaches, so much so that we are even taking it to a new level with new partnerships, such as that with Health Equity across the state. And we are so lucky and excited to be at the table. A big thank you to the Indiana Department of Health and all of you for your partnership and trust in us. Finally, being a part of a global health crisis, we had an opportunity to come together and work as a team. From a broader CTSI perspective, our mission is to accelerate translational research from lab to the community. And as a program overall, we had an opportunity to do just that. We offered the AstraZeneca trial. We worked with all of you to disseminate resources. We reached out to our partners and communities to find ways to get the vaccine information out. You all played a critical role in this success. So a big thank you to all of those involved, and that includes all of you in the virtual room here. I know it isn't easy, but it is a testament to our investments prior to the pandemic and to the continued passion, commitment, and stamina that all of you have. You provided a path for connection when we no longer had a physical one. I am hopeful for our future, knowing that you all are out there, our arms interlocked and ready for the next challenge that comes our way. Take care, everybody. Bye-bye.
Thank you so much, Dr. Wiehe, for your kind words. Anybody else need a tissue? I feel like every time I hear your stories, I need a tissue. But anyway, thank you for sharing and for your words of encouragement. Thanks everybody for joining us today. I hope that you made some connections and learned a few things. We will be sending out additional communication with an evaluation. We would love to have your feedback to tell us how to improve for next year and what went well this year. So please do watch for that link and give us your input. Also, you should be receiving information in a week or so whenever we have all of the videos and recordings from today edited and ready to go, as well as the slide sets that the presenters are going to share with us. So you should be receiving that information as well. If you have any questions or any needs, want to follow up on anything, please do not hesitate to reach out to us. We'd love to hear from you. Thank you again for your resiliency and for your passion and helping people across Indiana and working with us. And I hope that you have a great rest of your Thursday and a fabulous weekend. Thanks, everyone.